afternoon, everyone. Thank you for joining us today. As a presenter, my name is Kenny, and I'm here as one of your hosts. I'm here to welcome you to one of the many webinar series for NMAPA. Today, we will be discussing Medicare, what you need to know for patient advocacy from a certified Medicare counselor perspective. As we go through the information, please feel free to ask questions at the chat box below. We will answer at the end of the of the slides in lieu of the time. And here is the agenda. Overview of the Medicare A and B and D, comparison of Medicare Advantage plans, Part C versus Medicare supplements, Medigap plans, screening patients for Medicare savings programs, MSP, and low income subsidy, LIS or extra help, tips for using Medicare plan finders. And our host is Geraldine Arneson. She is a certified Medicare benefits counselor through SHIP, the State Health Insurance Assistance Program. She volunteers at Senior Services of Southeastern Virginia Counseling, new to Medicare patients. Prior, active duty Air Force pharmacist, board certified oncology pharmacist, a revenue integrity pharmacist. Without further ado, here is Geraldine.
Thanks, Kenny. So yeah, I have a lot of titles and I've held a lot of roles. I think maybe what might surprise you is that like prior to 2014, 2015, I knew close to nothing about Medicare. So it's something that I know everybody struggles with. I think part of that is because there's just an overwhelming amount of information out there. And what we need to do is kind of narrow it down to how do we apply that to what we do on a daily basis. So that's what I'm hoping to do with this. And we got a really good turnout for this webinar, which I think tells me this is a needed education platform, that, you know, everybody needs some help in this area. And so, you know, I think we can turn this into like a series of different Medicare topics to help you incorporate some of these things into your daily practice. Okay, go ahead. So what's a Medicare benefits counselor? So again, I knew nothing about Medicare, and I know, so, you know, I worked military medicine for a long time. In 2014, I went to civilian medicine. I knew nothing about Medicare, but in 2016, 2017, when I really started working with the prior authorization staff and, you know, making sure infusions were getting paid for, whatnot, I personally struggled. Like, I couldn't figure out what the difference was between a Medicare Advantage plan and a Medicare supplement. And then you throw in the term Medigap. I didn't know Medigap was the same thing as a supplement. I didn't know anything about the coverage gap for Part D. I didn't know any of these things. And so I just did a search on the internet, and I was looking for online courses to do some training. And so I came across, well, if you volunteer for senior services, which is available in all states, by the way, through the National Council on Aging. But if you volunteer to do this, you know, counseling these new to Medicare patients, you can get this free training. And so I did like 20 modules on Medicare. So again, I don't think everybody needs to do the 20 modules. I'm hoping, you know, what I can do again is narrow that down for you to what you do on a daily basis. But we give free Medicare benefits counseling, and it's in every state. We don't receive any sort of commission for doing this. We are not the same as insurance brokers. And probably all of your Medicare patients are getting called by insurance brokers like 3 times a day right now during open enrollment. The goal is to explain all the options available to the patient and let them decide what avenue is best for them, is what's going to meet their medical needs. So we provide this for all Medicare beneficiaries, so 65 and older, and those who are 65 and younger on disability and eligible for Medicare. So I have the link there in case, I have had some people send me a message and ask me how can they become Medicare benefits counselors as well. So go to that senior resource guide and you can find your local SHIP in your state. And if you want to pursue that path, I would encourage you to do so because it's very rewarding. Okay, next slide. Okay, so obviously here are the basics of Medicare. We've got Part A, which is your hospital insurance. This is like a very overly simplified. Part B, medical insurance. Part C, there's really no Part C, but we refer to Medicare Advantage plans as Part C. And then there's Part D, which is the prescription drug plan. Next slide. So this is kind of what I initially give to my new to Medicare patients that sit down, and I show them the difference between original Medicare and a Medicare Advantage plan. So original Medicare encompasses Part A, hospital, Part B, medical. You have the option to add Part D. I always encourage them to enroll in Part D because otherwise they can incur a penalty for not enrolling. And then you also have the option of adding a supplement or a Medigap. Okay, so you can use those interchangeably. A supplement and a Medigap are the same thing. Whereas a Medicare Advantage plan wraps up all of those things except for the supplement. So it's got Part A, Part B. Most of them include Part D. They have some extra benefits like dental, vision, hearing. Some plans include lower out-of-pocket costs. I'm not sure that's necessarily true. But if you go with the original Medicare plan and you don't have a supplement, you don't have a cap on your out-of-pocket expenses. That's the problem. With the Medicare Advantage plan, you cap your out-of-pocket expenses. And we'll get a little bit more into like who I would recommend to get what and why a little bit later. Okay, slide. Just briefly going to go over Part A because all of us who are in either patient access or patient assistance, financial navigation, we spend our time mostly in Part B and Part D, right? So I just wanted to let you know Part A, and this is for your reference. The slides are going to be available on the website after the webinar. This is just solely for your information in case you wanted to know like how much it costs a Medicare patient for an inpatient stay, a SNF stay, home health, hospice, all of that. Okay, next slide. Next slide, thanks. Okay, Part B. Here's your medical insurance. So if you live in an infusion center like I do, Part B is probably the most important part to me. That's your medical insurance. It covers your infusions, your chemotherapy, immunotherapy, your other biologics for immunology, neurology, rheumatology. It can also cover some outpatient medications like some oral chemos, your nebulizers, which I think are considered durable medical equipment, and immunosuppressants. Then it also covers all of these other things, doctor's appointments, preventative care, home health, and your ambulance services. And so your Part B yearly deductible is going to be $203 for 2021. And if you have a supplement, so I'm not sure this is really relevant, but just something to keep in mind. If you have a supplement, the supplements will no longer pay for the Part B yearly deductible, unless you have one that currently existing that covers it. Your Part B coinsurance is 20% after your deductible is met. So like I said, if you don't have a supplement, this is where things can go really wrong for a patient with this 20% coinsurance. So for those of you who live in the infusion world, you know, some of these infusions can be $10, $20, $30, $40,000. Now the 20% is based on what Medicare will pay for that infusion based on the dose. So even if the Medicare allowable amount is $10,000, like that's what they're going to pay. Even if we charge $30,000, Medicare is only going to pay $10,000. The Part B coinsurance for the patient is going to be $2,000 or 20%. And so if they don't have a supplement and they just have Medicare Part A and B, and they don't have a Medicare Advantage plan, that means for every infusion, they're going to owe $2,000. And you can see why that would rack up really quickly. Okay, next slide. Okay, Part D, your prescription drug plan. These are run by private insurance companies. I will say most of your Medicare Advantage plans include Part D, but there are some that don't include Part D, and that's because there are like state employee retirement plans that provide prescription drug coverage. And so if that's the case and you don't need prescription drug coverage, you can find Medicare Advantage plans that don't include Part D. The good thing is there's no pre-existing condition clause, meaning they can't exclude you. You're not subject to medical underwriting. And each of the plans have different formularies, cost structures, and preferred pharmacies. I recommend that the individual plan should be reviewed each year during open enrollment, which is going on right now. So each year, open enrollment is October 15th to December 7th. And I always encourage my patients, let's take a look at your Part D plan. Let's take a look at your Medicare Advantage plan. Let's make sure that all of your drugs are going to be included on your plan for the next year. Because if it's not, we may have to look at getting you onto another plan. So, you know, because if the formulary changes and that drug is no longer on that plan's formulary, now you've got to do, you know, twice as much work to try to backpedal and get them access to the medication. Okay, slide. This is just an example of what the tiers look like under a prescription drug plan. You know, tier 1 is your generics. Tier 2 is your more costly generics. Tier 3, so here's where you kind of get into the preferred brand, where it's really different between the plans as to what their preferred brand is. Tier 4 is their non-preferred drug, and so you're going to pay more out of pocket for a non-preferred drug. Tier 5 is specialty. Those are your oral chemos and all of the things that run through specialty pharmacy. Again, every plan is different, and the right plan is based on what medications the patient is on and the pharmacy preference. Okay, slide. Okay, I do not in any way expect you to memorize this or know this by heart. This is just for your reference. We're going to put this in a PDF file and upload it to the website. This just kind of breaks down the cost sharing in the Part D plan. So 2020, as of the end of 2020, the donut hole is gone. I'm not sure if you have practiced long enough to know what the donut hole used to be. When it started, was once they got into the donut hole, they were responsible for 100% of the cost of the drugs. And so now they don't like to refer to this coverage gap as a donut hole because the patient only pays 25% for both generic and brand name drugs. And so you're probably asking yourself, like, what is the difference between the initial coverage period and the coverage gap? Because on both, the beneficiary pays 25% and the plan pays 75%. But in the coverage gap, it differs by the plan only pays for so much, and then the drug manufacturer provides a discount on the rest of it. And so on the side, you can see once they get to that dollar amount, they move on to the next phase of the coverage. And finally, once they, the spend gets to $10,048, and that's beneficiary and the plan, then they reach the catastrophic benefit period. And so at that point, they're either going to pay a 5% coinsurance or $3.70 for generic, $9.20 for brand or non-preferred. And so they'll remain in that catastrophic benefit period for the rest of the year. So, and this is where your chronic condition and oral chemotherapy, those are the patients that end up in the catastrophic benefit period really quickly. Okay, next slide. And this just kind of simplifies that last slide. If you're just curious about who pays what and when, this is just a diagram of that. Okay, next slide. Okay, so Medicare Advantage plans. These are also offered by private insurance companies. They are structured like an HMO, a PPO, and then there's a fee for service. You have to use the doctors and the hospitals that are in the plan's network. It combines Part A, B, and then again, can include D, doesn't have to include D. Some additional benefits that aren't covered under original Medicare: dental, hearing, and vision. I'll just say a little blurb about this because I really feel like this is a struggle for Medicare patients. The benefits are really limited. Like maybe they might pay for a cleaning or two and some x-rays, but they don't pay for a tooth extraction or a root canal or whatever. Where you run into problems, specifically in oncology, is that a lot of times patients need dental work prior to radiation therapy. And if they have a Medicare Advantage plan and they don't have good dental insurance, it's very tough to find them help for the dental issues that they need taken care of. So you can either stick with the basics of what the plan offers you and just pay out of pocket, which really isn't realistic for most patients. You can pay a higher premium for some additional benefits through the plan. Even the additional benefits really don't cover that much. I oftentimes just tell them, if I know that something's going to become an issue, I would have them purchase a separate plan that is outside of Medicare. And then the other thing that they throw into the Medicare Advantage plans are the wellness programs, like Silver Sneakers is the number one that comes to my mind. The premiums, copays, co-insurance, deductibles, they all vary by plan. When you have a Medicare Advantage plan, you still have to pay for the Part B premium, which for 2021 is $148.50. Usually your Part B premium is just deducted from your Social Security check. It doesn't have to be, but that's what most people do. But the most important thing is that it limits your out-of-pocket costs. Okay, so now in contrast, let's go over the supplement plans or the Medigap plans. These typically, okay, so these are going to work with you. You have to have Medicare A and B. You can add Part D. You can add a supplement. You can't add a supplement if you have a Medicare Advantage plan. So like, let's say your Medicare Advantage plan has an out-of-pocket max of $6,700. You can't add a supplement on top of that to pick up the $6,700. So it only works with traditional Medicare A and B. The monthly premiums are higher than the Medicare Advantage plans. And a lot of times that's why I love senior services, and I wish more people knew about senior services. But unfortunately, you know, sometimes what happens is patients are kind of hit up in a parking lot of a store by a Medicare Advantage plan broker and are told about these zero premium Medicare Advantage plans. And of course, you know, the patients think zero premiums, oh, that's fantastic. But they don't know about their out-of-pocket costs. So your supplement basically picks up the 20% coinsurance from your Part B. Or this is a better example of what the different supplements will and will not cover. I like to call F and G the Cadillac plans because, as you can see, they pay 100% of the coinsurance for all of those things. Plan F is no longer available to new enrollees, but if you have Plan F, you can keep Plan F. And so G is what ideally, like if you had a cancer patient or, you know, someone with really high out-of-pocket costs, ideally I would like them to have Part G. So when I talk to patients about either going for a Medicare Advantage plan or going for a supplement, and they start kind of going towards the Medicare Advantage plan, I kind of say, you know, the way I look at it is we all fully insure our vehicles, right? Why wouldn't we fully insure ourselves, especially if we have a chronic condition? So that's just my point of view. Interestingly, with the supplements, so if you can see all of those different letters, those are all different supplement plans. If you look at the G plan on the right-hand side, you can see all of the different premiums for Plan G. These are all different, you know, there's AARP, there's Anthem, and you can see AARP is $14.58 and Blue Cross Blue Shield is $11.76. All of the plans within that letter are required to offer the same things. So they're charging various amounts of premiums. I don't know what it's based on, but they're not getting any additional services for that. So, you know, just something to keep in mind if a patient wants to go into a Medigap plan is to shop around and don't just take the first plan that's offered to them. So also really important about supplements. So we're all going to have patients that turn 65 who may have been on commercial insurance before, now are turning 65 or retiring and are going to be on Medicare. They have 6 months from the date that they turn 65 and have Medicare Part B to enroll into a supplement without being subjected to underwriting. So, which means they can't be excluded for a pre-existing condition. And that's huge. Once you get outside that 6-month window, there is another exclusion or there's another opportunity. But like if it's 5 years down the road and they develop cancer, to try to get them back into a supplement plan is, I'm not going to say it's impossible, but it's going to be extremely expensive. So the other caveat to this is if they got enrolled in a Medicare Advantage plan for the first time, they're not happy with it, they can go back and get a Medigap policy and a Part D plan within 12 months of joining the Medicare Advantage plan. They just have to do it within 63 days from the date they leave their Medicare Advantage plan. So that's another opportunity. This is just comparing a Medicare Advantage plan to a supplement. Monthly premiums for Advantage plans are low to no premiums. Medicare supplement, I mean, you know, we're talking $80 to $120 a month. But when you add that on top of your $144.50 for the Part B premium and then your Part D premium, you know, you could be looking at somewhere between $200 to $300 per month in Medicare premiums. So again, that's another reason patients go with the Medicare Advantage plan. Can you go back to the previous slide? So the other way I explain the Medicare Advantage plan is it's kind of a pay-as-you-go. They like nickel and dime you to death for all of these services. Whereas the supplement, you pay your premium and then it picks up all of your out-of-pocket expenses. You have to use the network of doctors for the Medicare Advantage plan. For supplements, you can see any doctor that accepts original Medicare. It doesn't require referral. Prior authorizations aren't required. In comparison, Medicare Advantage plans typically need a prior authorization for medical benefits and they need a referral. Okay. So now we'll go back. This is very similar to the slide I showed you in the beginning. So hopefully this makes a little bit more sense now. So you can go one of these two avenues, original Medicare Part A and B. You add the drug coverage plus or minus the supplement, or you go in the direction of the Medicare Advantage plan, and then you just decide if you want a plan that includes prescription drug coverage or not. Okay, so one of the most common questions I get is like, how do I identify, I don't know the difference between a Medicare Advantage plan and a supplement. And probably those of you that work in patient access that do prior auth, this is probably easier for you than it is for people in the patient assistance space, especially pharmacy people that are in that space. So I just wrote down, you know, like, let's just pretend this is the schedule. And I was looking at the primary coverage and secondary coverage. For Medicare Advantage plan, I'm going to see it a lot of times in the title, it says Advantage plan. It says HMO or PPO or PFFS. Typically, there's no secondary coverage on these patients. So that's kind of how I approach it. Okay. Oh, I'm sorry. When they have a Medicare Advantage plan, what's really important is when they go to registration or check in, they're going to get a new Medicare Advantage plan card. So although they can show their red, white, and blue card, they really need to show their Medicare Advantage plan because that's what's going to be billed and not original Medicare. Okay, so then in comparison, when I'm looking at Medicare with a supplement, again, pretend schedule. My primary coverage is going to be Medicare A and B. And these are just some, you know, you probably heard of some of these supplements on late night TV commercials like AARP, Mutual of Omaha, Colonial Penn. You know, sometimes it's confusing because they'll say life insurance company, but, you know, they actually have a supplement. But so in these cases, they need to show their Medicare red, white, and blue card and the supplement card. Okay, low income subsidy. So low income subsidy is the same thing as extra help. So get used to using those terms interchangeably. There's also full extra help and there's partial extra help. And the next slide is going to break, or in a couple of slides, it's going to break down what the income and asset limits are. But this is designed to help people who don't have resources pay for their Medicare drug costs. If the patient has Medicaid, if they're enrolled in a Medicare savings program, or they have supplemental security income or SSI, they automatically receive extra help. At the bottom, that's just, you know, a little snippet. Different Part D plans cover different drugs. If you qualify for extra help and your plan doesn't cover a drug you need, you have more opportunities to change Part D plans than you would if you didn't have extra help. You would only have an opportunity during open enrollment. Okay, so here's where you can incorporate signing someone up for extra help in your workflow if you wanted to. So I've got the website here on the slides. It's incredibly easy to do. So you can either sign them up directly through the Social Security Administration, or go to the next slide, or this benefits checkup website through the National Council on Aging. Love this website. Has so many resources, but you can sign a patient up for extra help through the benefits check. Okay, Medicare savings programs. This is where the state helps pay for Medicare costs if patients have limited income and assets again. I just listed, I don't expect anybody to memorize all of the different Medicare savings programs. The next slide, it's going to show you what covers what.
Hey, Carolyn, can you explain a little bit more about the difference between low-income subsidy and those savings programs? I think there's a lot of confusion that sometimes falls around that.
Oh, sure. Okay, so low-income subsidy or extra help is meant to help with your outpatient prescription drugs. Your Medicare savings programs are based, so it's going to include extra help. So it's going to help with your prescription drugs, but it's the different Medicare savings programs cover different things. So you can see on here, QMB pays Part A premiums. If they're already not free, they pay Part B premiums, deductibles, coinsurance, and copays. So again, this is a resource we're going to put on a PDF file and load it to the website for your reference. These are the income guidelines for 2020. They haven't come out with 2021 yet, but as soon as they do, we'll update that for you. One thing I do want to mention is, you know, getting the patient on Medicaid if they're that low income. That is a possibility as well. However, they can't qualify under Medicaid expansion, which is 138% of the poverty level. They have to qualify under the full ABD Medicaid, which is 80% of the poverty level. Okay, so here's where it gets a little bit confusing. I get a lot of questions about this, about whether patients who have Medicare are eligible for medication assistance. This is the way I kind of, number one, yes, they are. Okay. Patients with Medicare Part A only, remember that just covers the hospital portion. So I basically treat them as being an uninsured patient. They don't have any coverage for Part B or Part D. And so I typically apply for free drugs for these patients, or, screen them for, Medicaid or something like that. Patients who have, I see more often than I want to see, I have patients who have Part A and Part B only. And those patients scream to me that they just didn't receive proper counseling on picking an appropriate Medicare plan. So again, these have the 20% coinsurance for Part D drugs that go on. And so that 20% is for every infusion. There's no out-of-pocket max. So you could try to find a foundation with a fund that has enough money that could pick up all the coinsurances. We all know how difficult that can be. Free drug is usually approved for these patients. But what I would do is during open enrollment time right now, I encourage these patients to at least get into a Medicare Advantage plan so that we can cap their out-of-pocket expenses from the Part B coinsurance. Okay, medication assistance for Medicare Advantage plan patients. So they may need help with infusions or oral medications billed under Part B. They have a 20% coinsurance until they hit their out-of-pocket max. $1,900 was the lowest out-of-pocket. It's dependent on the state as far as what the out-of-pocket max is, but it's as high as $10,000 in the state of Virginia. And then their prescriptions are billed under Part D. They are not, so that 20% coinsurance, they're not eligible for manufacturer copay assistance. So we have to look to the different foundations like PAN and HealthWell and Cancer Care, and I'm missing a lot of them. But the good thing is, if you can get them into a foundation, once you pay off their out-of-pocket max, all their other services are covered at 100% for the remainder of the year. So that's kind of best case scenario for the patient. So you could get free drugs for them. That would benefit the pharmacy probably because we're reducing the drug spend, but really getting them enrolled into a foundation is going to be what's best for the patient. So, I deal with a lot of Crohn's and ulcerative colitis patients. There's never any foundation funds available for those two disease states. So what I'll do is I'll apply for free drug until a foundation fund opens up, and then I'll get them into it after that. Okay, so medication assistance for patients with the other pathway, ABD, and a supplement. So they typically don't require assistance for infusions or the oral meds billed under Part B, because that supplement picks up the 20% coinsurance from Part B. They may require assistance for Part D medications because supplements don't cover the coinsurance for Part D medications. So again, you need to try to find foundation assistance first because they're not eligible for manufacturer copay assistance. Your last thing you can always try is the state pharmaceutical assistance programs. These are really hit or miss. It all depends on the state that you're in as to what's available. In the state of Virginia where I live, there's only one assistance program through the state, and that's for HIV. So it's worth taking a look if you can't find anything else. So, okay, Medicare insurance optimization. So, this is kind of the buzz terminology right now in the patient assistance financial navigation space is how do we optimize somebody's insurance? Usually that just means, someone maybe doesn't have insurance, and so we're going to get them on Medicaid because it benefits all of the services. For Medicare patients, if I'm going to optimize their insurance, if they're a Medicare A and B only with no supplement, I'm going to try to get them into a Medicare Advantage plan. Now, I can do that during open enrollment. I can wait from October 15th to December 7th, or a little tidbit that people don't know about is that you can enroll someone into a 5-star plan any time of the year. And I've actually gotten patients on Medicare Advantage plans going through the 5-star plan route. And so that's been a really beneficial tool for me. For patients about to turn 65 with cancer or chronic condition, I'm supposed to stay neutral as a Medicare benefits counselor, but I do encourage the patients to purchase a supplement if they can. They have 6 months, again, from when they turn 65, where they're not subject to medical underwriting and can't be excluded for pre-existing conditions. The higher premiums, again, we fully insure our vehicles, but we won't pay the higher premiums to insure ourselves. So, one of the easy, I think, low-hanging fruit things that you can do is you've already got to collect proof of income for other assistance programs. Look at that income and screen them for the Medicare savings programs and the low-income subsidy, aka extra help, and help them enroll in that. And okay, so I was going to go through the Medicare Plan Finder with you all, except they've added this new feature where you can actually compare Medigap or supplement plans this year. And so I really we're going to break that out into a separate webinar so I can, go through the Medicare Plan Finder with you and help you select programs. So here are some of the future Medicare topics that we were thinking might be needed. One I really want to go over is legal and compliance for the advocate when it comes to Medicare. If you see if you are thinking of a topic that is not on this list and you feel like it's a sore spot in your workflow, please reach out to us at info@nemapa.org and let us know about it. And we'd be happy to, create something around that. So with that, I'm going to open it up to questions. And I want to say thank you to everyone for the great turnout and attending. And I hope this was helpful in some way. And if you have additional questions, again, feel free to reach out to me through NMAPA or on LinkedIn. I'm happy to help you with any, patient issues you might have that involve Medicare.
Well, I'm actually going to cut you off there, Geraldine, and intercede. Hey, guys, it's Elizabeth Johnson. And before we get to questions, I just wanted to, extend a big thank you to Geraldine, who is one of the founders of NMAPA with us. And it's so valuable to have her knowledge and to be able to tap into that anytime, which I do fairly regularly. But again, we are presenting the Healthcare Advocate Summit next year in Galveston, Texas. And so this is a chance to come and meet and greet with all of us in person if we are allowed to, and fingers crossed we can at that point. But your advocates that do this every day are going to be there. This is an opportunity to network, to learn, to further develop your career. And we want to support you, and we hope that you support us. These are some of our fellow sponsors that have made this possible for us and have made this conference a reality, where instead of passing notes and begging and pleading, does somebody know somebody here? We're all going to come together and we're going to talk about these things that we all do every day, build that community where that pathway is open and we can ask questions and get answers and give much better care to our patients instead of scrambling and phoning friends, as fast as we can. So again, thank you to everyone today for being on. Thank you to these sponsors. And we hope that if you're enjoying this material, You will join in the MAPA, find us on various social media platforms, as well as personally connect with us, and we can help rope you in. So let's get to some questions. Geraldine, you had quite a bit of questions come through. I had to take notes as we were going. So we'll start with the first one that we got. Is it still true that supplemental plans pay about 80% of the remaining 20% on the Part B side?
Well, it depends on which letter plan that you would choose. So let me, on my end here, go to the supplement side. So like Plan L pays 75% of the Part B co-insurance or co-payment.
So is it safe to say that it varies by plan?
It varies by plan. So K and L only pay a portion of that 20% co-insurance. The rest of the plans pay 100% of the co-insurance.
Okay. And what would we do for patients that are Part A eligible but have declined Part B because they're still working? How does that impact copay assistance for patients?
Well, that's a good question.
That was my question, so you know.
Yeah, I was going to say, I think that you know the answer to this better than I do. I'm going to defer to you on this one.
Oh, I think a lot of these copay manufacturer programs, they check for Medicare Part A coverage. And if you have a patient over the age of 65, doing your due diligence in screening, we look for those. But I would love to dive into that topic further because that's a big thing in my area. So next question.
Yeah.
Any tips for how to find out primary and secondary coverage if the patient only provides Medicare or Medicaid card?
So so you could actually go to mymedicare.gov, and if the patient gives you consent, you can create an account on mymedicare.gov for that patient, and you will put in the information from their red, white, and blue card, and it will actually pull up what insurances they have. And it will tell you the coordination of benefits, like what would be billed first.
So for compliance sake, is that a written consent, or a patient can give verbal consent and we document they gave verbal consent?
A patient can give verbal consent. And we do this oftentimes, one, because it's creating an account is difficult for the patient and they're not really sure where to go to. And so, as long as we're having a discussion about it and I'm explaining what I'm doing, I just document it somewhere in the chart that, I got verbal consent from the patient to be able to do, kind of an investigation of what their insurance coverage looks like.
Okay. I'm going to read this next question to you. And this is in abbreviated Medicare terms, and I'm not familiar, so you may have to explain them to me. Is ABD 80% FPL in every state?
I believe that is true. However, it could be, so I don't want to say definitely yes. I would say that might be something I have to look up, because with Medicaid expansion, that not every state has done Medicaid expansion. So in some states, it could be 100% of the federal poverty limit. I would have to look that up and
we can get back to
you.
that one. That may be a great topic to talk about there, or create a chart.
Yeah, I was kind of thinking, if we could list all of these questions, and then I could find the correct, I want to make sure I'm giving you accurate information, but we could, always email that out to everyone.
Oh, we already made a list. We'll do that. Don't worry.
Okay.
So for the patients, when you're looking at low income subsidy and some of these other things, and they're looking at assets, what are considered assets for these plans or to these plans?
It is listed on slide 26, I believe, the assets, checking, savings accounts, investments, stocks, bonds, certificates of deposit, the value of some life insurance policies, retirement accounts. What's not included are personal belongings, household furnishings, one auto. That's important. Your one car is not included, burial plots, and primary residence.
Sounds very similar to bankruptcy stuff, but
Yeah.
don't hold me to that one. And then this last question that we've received, kind of a scenario here for you. So, and I enjoy talking these through with you. What if the primary is Medicare with no prescription coverage, but they have a supplemental, let's say AARP, that does have prescription coverage? Patient responsibility for cost of medication is unaffordable. How do you go about that? So they've got a supplement with prescription coverage, but no true Part D is what it sounds like. How do we get them?
You know, I swear, I feel like I've heard every possible outlier scenario, and then something else like this comes up. There's just because of the complex nature of Medicare, there's just endless possibilities of what could happen. I guess if they couldn't afford the co-insurance from the supplement for their outpatient prescription, I would look for foundation assistance first. And then if I couldn't find foundation assistance, I would go ahead and fill out the application for whatever the drug access program is. And the manufacturer will determine whether or not they're eligible for free medication.
Okay. So there's different scenarios. And I think, again, this is the whole value of NMAPA as an organization and the community sense that we're trying to bring, is that these questions come up and sometimes we just have to talk through them. Sometimes we have to go back to the drawing board and research and come up with different scenarios and play through them all. And that's the beauty of experience. That's the beauty of training and education, and really, building upon what we all know. Because Geraldine, how many times a week do I call you for questions? So
yeah, and what's interesting is by being a certified Medicare benefits counselor, I'm assigned a unique ID number, so I can call a special Medicare line and ask questions, like especially when I'm doing these new to Medicare counseling. What's interesting is I'll call the Medicare line, I'll use my unique ID number, and they can't answer my question, and they refer me back to Senior Services, which is the organization I'm volunteering out of. So sometimes the Medicare help desk can't even answer some of these questions because they're so complex. And so sometimes you just have to try different avenues, and that's how you learn.
I think that's always makes me, giggle a little bit when you say that. But I know everyone is short on time, and we appreciate the hour that all of you have spent with us. Again, thank you, Geraldine. I appreciate that. Thank you to the NMAPA team. We've been running tech support and Q&A in the background, and we certainly couldn't get this organization off the ground and running with all of this without the support of everyone here. So thank you, guys. We'll give you back a couple minutes of your lunch hour or morning, depending.
I'm going to say one last thing. And I really want you all to, I want to encourage you to ask questions, to email us questions. There's no stupid question, especially when it comes to Medicare, because we're all at varying knowledge levels. And knowing that I came from zero knowledge level of Medicare, and I'm not going to say I know everything about Medicare. So I don't want anybody to feel self-conscious about, that we would think you should know something like that. Like, please ask your question, because at the end of the day, there's a patient on the other end of that. And our goal is to help you help your patients. So please send us your questions.
All right. Thanks, everyone. We appreciate your time. Have a great day.
Thanks.